No, not for the name of the truck. The truck is named after Britney Spears, who is the best woman ever created. I think everybody can agree. But yeah, one of my friends was saying how he was like, I thought this was all going to be in a truck. Why are you putting the truck in there? But my truck is my best friend, the most gorgeous and scary woman I've ever met, but dependable and loyal. So anyway, welcome to Tim Talk Live, episode 2. We're here with Rich Napolitano. Thank you very much for joining us. I've gotten a lot of interesting response from the first episode. So one of the things we're going to do is some folks said that they wanted to have their wanted to comment. They weren't sure if they could ask questions. So we're going to now allow that, but I want to let you know it's probably not going to be answered in real time because we have a lot of stuff we're going to try to talk about. But definitely by the end, if you stick around to the end, we will get to all the questions that they might have for you, Rich. Okay?
Sure.
All right. So FQHC. So we were talking before this thing started, and like I said, I think you're probably blind to this because this has been your entire career. But most folks do not know even what an FQHC is. Or what do you typically call it? A health center? Is that usually the more common term that?
Health center, community health center. FQHC is federally qualified health center.
Okay.
Yeah.
So some of them more funded by the Fed than they are by the state? Is there a difference there?
Yeah, federally qualified health centers all receive federal funding. HRSA.
The inspections from HRSA and all that, so they have higher regulations.
330 funding at various levels, and it depends on numbers of patients and the communities that they serve. That determines their funding levels.
Okay.
Yeah, and so, as you know, as a former board member, HRSA 330 funding can be a significant part of a health center's budget, or it can be not as large of a part in the bigger health centers.
So are there some that are just completely funded through the state and do not receive federal grants?
There are health centers throughout the country that are called lookalikes that don't get that federal funding.
Never heard of that.
Yeah.
Interesting. Yeah. And is that because they're typically smaller in stature, or
I'm not sure exactly what the reasoning is. I know they don't get the federal funding yet. Some of them will be vying for that, but there's others that don't access that funding, and I'm not sure exactly the full reasons why. Yeah.
And so what kind of services typically do FQHCs or all community health centers, what kind of services do they typically provide? Primary care, dental?
Dental, yeah, for the most part. I think there's only 1 or 2 in Massachusetts, for instance, that don't provide dental on site.
Yeah.
But for the most part, dental,
OBGYN, I imagine.
Primary care, sure. Yeah, okay. OBGYN. I mean, like Greater Lawrence, where I used to work, they deliver, their staff is delivering babies next door at Lawrence General Hospital, hundreds of times a year. So,
but probably not so much under specialties like surgeons and oncology and things like that. So a lot of the specialist practices won't typically be covered, but you guys would refer to those folks.
Sure, absolutely.
Or I should say community health centers would refer to those
I mean, FQHCs are really a community health provider focused on the mission being focused on the underserved populations.
So, which is really the center of why anyone gets into this. So I want to ask you why you got into this stuff in a second. I mean, I'd like you to first let us know about like these underserved populations. So it's something that is very alluring because generally speaking, you have folks who are like immigrants who might not speak English. They might not even be familiar with the law. Like I remember one of the members that I met on the board, and the cool thing about the board is that the boards for FQHC have to be made up by majority folks who are patients of the health center.
Correct.
Which was great because it led me to become a patient of a health center and get an experience I didn't imagine. But I remember once one of the folks on the board was a caseworker, and she told me about this terrible story about some woman who basically was fleeing Haiti, came here with like 3 of her 5 children. I guess her husband was terrified. She was like fleeing him, really, not fleeing the country, but fleeing him, and came here, didn't speak any English, did not know our local laws, got some kind of housing. She had an infant. The baby was hungry. She needed to find milk. She left the baby, I think, in her apartment and went off to get milk or something. Someone next door in an apartment called the police, and she lost her child because she had no idea how the services work here. So like, it's impossible for me to imagine what it's like for some of these folks that are in a scenario like that. But it's not a terribly uncommon story. And most of the folks that are in health centers, not everybody, but certainly a lot of folks that it serves are the folks who are the most vulnerable, the most impoverished and threatened folks, right? That
Sure, absolutely. Yeah. The mission is focused on low income, underserved populations who probably need us the most in terms of their healthcare or their family's healthcare, regardless of their ability to pay.
Yeah.
That's part of the whole mission. This year I think is the 60th anniversary of federally qualified health centers.
Wow.
Actually, this year, 1965 was the first year.
I remember learning a lot of the history, and it's changed my mind on, like, being a part of that board changed my mind on a lot of things about how I view different folks who are suffering from addiction, homeless folks. Like, we had a great person who's like an author and that's dedicated his life to that came in as a guest speaker once, and certainly changed, like, how they said the most for homeless folks, the thing they care about most isn't even getting money from folks. It's literally just having eye contact, because every time someone sees them, they just kind of look away, and it makes them just feel subhuman. And like every once in a while, like me and my girls will go get, like, not that we have a lot of money, but we'll go and grab like a bag of like quarter pounders with cheese from McDonald's or something like that, and we'll hand, and they're so thankful and stuff like that. And it's I think it's very difficult for a lot of folks to understand that, but also especially these right now, where the funds that people have become, I think, very thin, and like affording housing and basic things like that the line between where you are right now and becoming homeless sometimes is not super thick. Like, if you don't have a lot of friends or family that are willing to help you out if life hits you hard, you can end up there quicker than you think. And it's a very scary thing. So what, for you particularly, is there something that personally hit you, or is it like just the mission, because you've dedicated your entire career to this?
Yeah, I mean, it's really been more the last third of my career. Most of my, the last 12 so years, but prior to that, I've always worked in nonprofits.
Okay.
Since I got out of graduate school. So when I really worked in community relations and fundraising and all that stuff. And at the time, my son had just gone into remission, had a cancer scare when he was younger, and I had taken some time off from my job. I left the job, and then when I was ready to go back, I fell into an opportunity with Greater Lawrence Family Health Center. I grew up in the Merrimack Valley, saw the opportunity, got a chance to meet a wonderful man, Bob Ngala, who was the CEO at the time.
Does anyone not love Bob?
Yeah, I mean, he was great. He was, what a fantastic guy. And I had an opportunity to learn more kind of right there, and just discussing with him and his senior team at the time, who I ended up working with for 9 years, what health centers were all about. And I was sold. And for me, it was like, it came in, it was like, storytelling, the mission is what I used to call it with my team. And, I really got into it. And then when our next CEO came in, John Silva, he introduced me to on a national level, to the community health center world and what they call the movement.
Right.
You'll commonly hear that. And I had an opportunity to meet a lot of wonderful people, and really was sold on it, and knew at that point that I would probably finish my career, hopefully.
Yeah.
Knock on wood, I'll stay involved with health centers through the rest of my career.
Yeah.
So that's really what it was really what it was all about.
Yeah. I remember being really annoyed that I got to the health center, I think, shortly after Bob had left. I never liked Bob because everybody loved the man. And I'm like, who's this guy? Like, how is there ever a person that everybody loves? Yeah. And so that annoyed me. And then I finally met him, and I fell in love with him too. And I was like, damn, I like this guy. He's just got such a great, he ended up helping out at the end of my tenure over there on the finance side. Yes. And I think after I left, he briefly took over as treasurer there for like 6 months or a year or something.
Yeah, we got him to come back, which was great. He was the interim CFO for a short time when we had a gap, and then he joined.
Oh, that's right too.
Then he came on the board and was involved with the finance committee.
Yeah, he's definitely a special guy, and he's a good guy to know. I invited him to this, so hopefully he's watching. And Bob's a great guy, and John was great to work with too. I enjoyed, like, I had good chats with him. And the cool thing too is everybody in this industry, in the health center part, is so fueled by passion. Like everybody cares, even if you have a disagreement. Everyone seems to really be pushing for the same thing, and you don't have a lot of environments where, like, if you have like a suit like me running a medical practice, often they're going to be profit driven and they're going to be focused on that, and the patient experience diminishes. And then often if you have clinicians running practices, finances go to hell because they're trying to provide, they're more focused on great care. That's why I think we often see CFOs and CMOs banging heads, because I mean, it's classic. And I remember even in Greater Lawrence, I saw that happen. I would tell people, I'm like, it's a good thing. You don't want a dominant CFO, nor do you want a dominant CMO. You want them to be able, you want them to fight with each other, because that means that both sides need to win. You need to make sure people are getting paychecks so your staff is able to come back to work and you're able to serve these patients, but you also have to make sure you have good health care. The health center market is really interesting because of that. And the weird thing about it, something else that I've learned, is although Medicaid is overall a big loser financially for states and for the Fed, Medicare likewise, Amtrak, other government programs, but FQHC is not something that works in the negative, and it's bipartisan. So the funding usually is threatened, right? Every time there's a government shutdown, there's a big threat to them. But typically Republicans and Democrats come together for you guys.
Typically, yes. Yeah. And then my work at Greater Lawrence, in the Massachusetts delegation, the health center delegation here through the Mass League, who we're involved with here as well, is tremendous at that, in terms of the grassroots advocacy. And because of John Silva, I was able to get involved in the grassroots advocacy stuff, not only in Massachusetts, but also nationally. Right. And that's where, the funding cliff and all that they talk about every few years. And, it is typically very bipartisan, but we still have to fight the good fight, though. And to make the case, I mean, NAC just came out yesterday. I believe it was the NAC is the National Association of Community Health Centers. They just come out yesterday with a number of it. Now it's over 34 million people in the country are getting their primary health care at a community health center. It's amazing. And most people don't know, like I said, to start this off, I was talking to some of my employees the other day that live in Brockton. They don't realize that neighborhood health center is a community health center. And I think that a lot of folks don't realize that there's probably one in their town or in a neighboring town. Yeah. I mean, there's over 50 in Massachusetts alone. Yeah. And I remember, and this is going to sound terrible, but I don't mind disparaging my own name. I remember the first time I was offered a tour, and I walked in and I was expecting something dingy, something dirty, or something that was not, and I don't know why that was my expectation. It's terrible, but it's what and I walked in there, and this is 10 years ago. So just to frame this properly, because a lot of folks have this tech now, but I walked in there and I saw this kiosk on the side, and I said, what is this? Why would there be a kiosk when people are walking in? They were like, oh, it's like the airport experience. I said, what do you mean? They said, oh, you just scan your ID, so you don't have to go up to the front, and they know who you are and what your appointment is, and you just click a button. Right. I was like, I haven't seen this at that time at any medical practice. And the place was beautiful. It was clean. The folks behind the desk were very pleasant to deal with. And I was shocked by that. And it's because anybody can go there, right? So absolutely. It doesn't have to be someone that's on Medicaid. Anyone can frequent. Sure. All different types of insurances, private pay. Yep. Okay. So yeah, and I found, like, I actually didn't know. I live in Attleboro now, and I found out that there's one in Attleboro. Yep. And I can't remember the name of it off the top of my head, but I'm probably going to be joining them soon too. Because I think it's great to be able to support the folks there. Okay, so you get into this because you love it. You've now moved on from Greater Lawrence to Commonwealth Purchasing Group, which
I originally thought was kind of like a GPO, like the Mass League, but you guys are like that, but kind of
Well,
different too.
we're a GPO that's owned by the Mass League. Mass League founded CPG back in 1998.
Yeah.
And it was as a GPO to look at opportunities for group purchasing, leveraging that spend for Massachusetts health centers.
Yeah.
And over the years, it's grown, and now we're a national GPO.
Yeah.
That's very well known throughout the country. We have close to 900 members now.
Okay.
At least one in every state. Some states more than others, for sure, but we're very much national. Our team is spread out. We're all located here in Boston, but we're geographically assigned. We assigned some folks geographically throughout the country to cover those states and the members in those states.
Okay.
Yeah.
Yeah. Because I know in Massachusetts alone, we were going over this earlier, there's over 50 in Massachusetts for health
Correct.
centers.
Right.
And I think over 250, somewhere between 250 and 300 facilities that folks can go to. So now that you have this post, what is it that you guys do to help out the health centers?
So as a group purchasing organization, our focus is really on identifying areas of spend for health centers that they typically could be pain points for them. How do we negotiate, bring in vendors, negotiate contracts to kind of lessen that blow, that financial burden, leveraging the spend of all of our members. So the key areas are medical supplies, pharmaceuticals, office supplies, translation services. Those are the big ones.
Okay.
But we have 90 different vendors in our portfolio. They're all directly affiliated with us. They're contracts that we've negotiated with. They're not with what they would call a higher channel partner like a Provista or a Vizient, although we do work with those ones. Those are some of the larger national.
Yeah. But you also have local groups that you work with as well, like in the various states.
Yep.
So some of the.
Yeah, we work with I would say we work with most of the primary care associations, like the Mass League throughout the country, with their affiliates of ours. So we work closely with them to really help in terms of endorsing us and leveraging what we can do for their members and what we can do for them.
Right. Because if you cut expenses, then that's going to just turn into all sorts of benefits for the centers.
Right. Right.
So how about for your vendors, do you just go for which ones will cut the price the most, or is there what's the process when you go through choosing? You're going through okay, here's Henry Schein, here's McKesson. They both do great things for medical supplies and equipment. And do you contract potentially with both of them, or is it typically an exclusive contract? And is it only based on what the discount is? Or
no, yes and no. I mean, we look at in those larger areas, we have some legacy relationships that I would say longstanding, that we negotiate with them every 3 to 5 years. Different opportunities, different pricing programs with them. We only have, out of all of our vendors, probably 2 or 3 exclusive relationships.
Okay.
Otherwise, in all the other relationships that we have, there we keep it open as an opportunity to bring on, not to be multi-source.
Yeah.
When I first got an example that I used often is when I got here, knowing what it was like at Greater Lawrence, all the different languages that were spoken, all the different, the different dialects of Spanish, for instance, at Greater Lawrence, with our Latino speaking population, our patient population. When I got here, we had 1 translation service vendor. We have 4 now.
Okay. That's so important.
But what we do though, typically in that process, the vendor process is they can apply through our website.
Yep.
We also, the ones that we're taking on more so recently, I would say in the last 6 months or so, are ones that come to us as referrals from our members or other people that we trust in the business. They're not just coming to us cold.
Yeah, which is really important. So this came up on episode 1 when we were meeting with Rosemary Spada last week, and she had mentioned how I was the 3rd billing company that she went with for her services. So we did her credentialing and her billing and stuff, but she was, I don't know what she didn't mention the association, nor should she have, I guess. But you know, there's a lot of organizations that will say, you pay X amount, you get this type of affiliation, you know, or for whatever the reason is, there's a process where people get put in a place of trust. People will trust their association, their membership, whether it's a GPO or an education place or whatever it is, a professional association. And then they haven't been vetted. So what you're speaking to is that so after you make these contracts, you reach out to your health centers and find out how well they're actually doing for them.
Yeah, we do that type of spot checking for
Okay.
sure. We depend on our members to let us know how things are going.
Yeah.
You know, we're also, you know, we're vetting vendors before we bring them on now more than we ever did before.
Yeah.
You know, because there's times, as you said, you know, we were talking earlier, there's some bad actors out there, right?
Absolutely.
So, you know, you get into a situation where you have a vendor that you feel like, oh, well, they're doing business with other health centers in other parts of the country that maybe aren't our members.
Yeah.
Or maybe they are, but when you really peel the onion, you peel the onion back and you really find out what they're like or what their process is. Do they really respect what you're doing for them as a GPO? Because we provide marketing opportunities. We push their product. We do webinars, we do learning sessions, podcasts, things like that, to really promote them. And our member resource consultants, that's our field team. And they're listening to what our health centers are saying, and they're our members, and they're saying, if they're saying, hey, we need this, who do you have?
Right.
We're going to go back to them and do a business review and talk to them about, this is who we have. This is who you should consider in our portfolio. You know, if you hear of somebody else that we should be talking to add to our portfolio, just let us know and we'll talk to that vendor. And that's happened a few times.
Yeah. And I've gotten the sense, because when I was looking into CPG, I noticed also that it doesn't just seem to be a pure GPO. Like you guys also have, like you were just saying, there seems to be education you provide or help out even with teaching them on things like advocacy or
well, that's really from our colleagues downstairs at the Mass League.
So Mass League helps out with that. So you guys do that in tandem with them.
Okay. Yeah, I mean we will, but I mean most of the work we do is GPO related.
Okay.
You know, for sure. The Mass League has a great policy team, government affairs and policy team that works on that, especially specifically for the mass health centers, not the whole country. We depend on the National Association to do that nationally, but our folks downstairs are really doing a great job with our Massachusetts health centers.
That's good.
Yeah.
Okay, great. So let me bring in another piece. So a lot of people might not know, although I don't think you're scared of talking about your affiliation with basketball, and this is a crazy tangent I'm making now.
Yeah.
But has nothing to do with it, but you know, I'm not really a professional at this stuff. So so you have this big passion in the basketball world.
Yeah.
Where did this come from? Is this mainly from being a father? Were you into basketball as a kid?
Yeah.
I will tie this in.
I was. I wasn't good enough to make it on the high school. No, I wasn't terrible, but I wasn't. The teams that we had at Andover. I grew up in Andover, born here in Boston, but grew up in Andover, and my grandfather was a longtime sports official in Maine, and I just got the bug when I was probably 15 and started officiating local youth basketball, and I've never stopped. And progressively, I've gone through the ranks of high school and getting certified with the national organization and then becoming a college official in the mid 90s. And I still do it today, you know, and now I assign officials as well to leagues and things like that throughout the year. Kind of being, you know, my hope is to be able to be more of a mentor and supervisor of officials someday. But I really still enjoy being on the court, and I still do it quite a bit. And it's really where my closest relationships and friends are beyond family. Yeah. You know.
Speaking of family, doesn't your son play as well?
My son is a coach. He's an aspiring coach.
Okay.
Yeah, he's an assistant coach right now. He graduated a couple of years ago.
How old is he now?
He is my youngest. He's my youngest. He's 20. 24. 24.
Okay. That's a lot older than I
Yeah, I
thought
have
he
3
was.
children, 24, 28, and 32.
Okay.
Yeah.
Interesting. Okay. Now, for the tie-in here, because I feel like officiating is kind of like a glutton for punishment type of thing. Like nobody likes you guys, right? Like that's going to be a tough position to
No,
be
we
in.
used to say we please 50% of the people 50% of the time. So no, it's not. And you gotta, I think that I've become a better communicator because of it throughout my career as
Yeah.
an official and my professional career. I've had the opportunity to balance them with each other too, and I've had some supportive situations where I've been able to do both, and it's really
Okay.
something I enjoy.
Yeah, because I think generally speaking, a lot of people don't get a lot of great feedback about their performance on things, whether it's like, in your career and things like that. Like you should get, but it's typically not honest feedback. I feel like often it's hard to really understand how you're seen by other folks. As an official, I believe it's the opposite of that. You don't ask for the feedback and you get more than you bargained for. So from a communication standpoint, I can see what you're saying, that it can probably help you out with being maybe more direct with folks or maybe
and having a thick skin.
I can't even imagine. Yeah.
Yeah. It's important.
Yeah.
Yeah.
Good.
Yeah.
Okay. So let's let's get into politics, because that's always good to talk about publicly, right?
Sometimes, yeah, sometimes we, I don't know if we have a written rule here in the office.
Okay.
But it's kind of like an unwritten rule. We don't get into politics much.
Thankfully, he's looking off camera because he has a coach that basically is going to go like this every time that I ask probably a very bad question, and she was yelling at me earlier. So so you don't have to answer any questions, or you can kind of give a gander. Oh God, I'm getting out.
Yeah.
I've gotten that look before, and I'm just going to keep looking at you now.
I'm glad it's only Emma, because if there was someone else, 1 or 2 others here in the office, they'd be saying, no, like, like the angel on one and the devil on one shoulder, and the other, some people would be saying, no, let him go.
See, this is why. So far we've just been exclusively Italian. You're Italian, aren't you? Yeah, it's very obvious. So basically, this is an all Italian like live stream at this point. I mean, next week we have this guy Jonas Bromberg who's gonna throw it off a bit, but there's no. We're not easy on each other, and we definitely have no problem.
And you started with an Italian.
I did, yes. It's the right way to do things. Right. You start at the top, and then that was really terrible, Jonas. Sorry about that. Hopefully you're not watching. So whatever it is that you feel comfortable answering, or that if you want to check off,
sure,
go right ahead.
Yeah.
So let's start with the big beautiful bill. So I've seen a lot of criticism on this, and I'm going to tell you my thoughts, which you don't have to agree with or not. But I know that there's all the intricacies in how it affects. When it gets granular, I don't know a lot. Like there are certain things that I liked in it, like the Medicaid stuff. It gets really dicey. You don't want to cut Medicaid benefits because potentially you're sending people out on the streets. A lot of the stuff that I've seen has been reinforcing stuff that's already on the books, like if you're like for SNAP, I think it was, and I'm not going to get this right, but close. Like if you're between 45 and 55 and you are not looking for work and you don't have any kind of disabilities or any reason why not, then you could be in trouble of losing your SNAP benefits. Or with like Medicaid, if you have no children underneath, I think it was 14 or something like that. And same situation, and I think they moved it from, you have to prove that you're looking for a job, from 12 months to 6 months. So to me, it seems like that's a good thing, keeping the program honest. But the reason why we also have Medicaid is because we don't want people on the streets and stuff like that. And there's going to be, with the amount of people that are on Medicaid, there will be folks that do not abide by those rules and can be threatened for their housing and their livelihood and their family. So it's tough, it's dicey. And then, like, what I would have liked, and you don't have to respond to any of this, is if the money that they're saving from that was going also back into the system for areas that are desperately in need, like mental health benefits, and because the Medicaid payouts are so low, so there are a lot of providers that don't want to take on Medicaid as a payer, and I guess that, so I'm kind of conflicted a little bit with the bill, but I know on the FQHC side of things, it hits you guys a little bit different. I'm not sure if you can speak to how it affects you, or if you want me to lead that, but.
No, I mean, what I do know, I mean, I don't know all the granular details
Yeah.
as much as I might if I was in a different role in my
Yeah.
previous life.
Yeah.
But I will say though that the health centers. I mean, there's a lot of concern.
Yeah.
If people are going to be tested to the point where they can't stay on Medicaid and have to come off, and so we have more that are uninsured,
Right.
or there's more hoops to jump through in order to qualify for Medicaid. That's going to be an administrative burden to the health centers. It's going to be a revenue hit for the health centers.
Yep.
I mean, being on a board and on the finance side, how much they depend on these that payment stream. Some of them are 75%, 75 to 80%
Yeah.
Medicaid. So it's gonna hit health centers hard, that part.
Right.
The work requirements that people are gonna have to go through. And we already have, some health centers have a significant percentage of uninsured, and it's just gonna raise that. Are people gonna lose their funding? That's the big concern.
Yeah.
I think. And I see it as an opportunity for us.
Yeah.
And I've said that to my team, that
That's a really good point.
we should see it as an opportunity, and we should capitalize on that. And I mean that not as so much as in a greedy way. I mean it in a way where we could be even more impactful or more effective,
Without question,
for our health centers, our members, and to say, hey, what are your pain points? Where can we help? Where a lot of them are looking into shared services now.
Yeah. Interesting.
Where can we help in that realm? Where can we help with, you're looking at shared services in the billing field or the credentialing. Can we identify, or translation services? Can we identify one or two vendors that will even cut their costs even more, just a little bit,
Right.
even more, where 25 health centers can all use the same one, at the same time. Are those opportunities for CPG?
Which is, I think, definitely, because I think that also goes back to what we were talking about earlier. So when you have exclusive contracts, there's less flexibility. When you have multiple vendors, so let's say, for instance, let's go back into translation, which I think is super important. And I think a lot of people don't understand how important that is. So when I was running my PD practice, we had this, the vendor we use are called Marty, Martti, I believe. And the reason we worked with them is because they had a video component.
Yep.
So, and a lot of folks didn't understand why it was so important. Like, why don't you just have an audio translation or something like that? But when I flipped the scripts and I said, okay, listen, let's say, for instance, you're going to India with your family, and God forbid something happens to, your significant other, one of your children, and you're now in an emergency department. And even if they have folks that can speak your language or anything like that, just think of how, or even if you can speak their language, but you're going through a different language and you're not super comfortable with it, but you're worried about your loved one. And then all of a sudden they bring out a video screen that has someone that looks like you, that sounds like you, that how all of a sudden you just start to feel naturally more comfortable. And there are so many folks, especially in community health, that English is not your first language. And I love that. And it wasn't a cheap vendor to bring in, but it was great.
Sure.
But now you bring in something like, you're right, it looks like there's a lot of new red tape, like a lot of new HRSA requirements and things like that are coming out. I think they're trying to offset them with like childcare vouchers and things like that for the entry-level folks that are working in health centers, which is good, but to try to prevent burnout and stuff. But there might be health centers that are like, we can't afford something like that. So if that was all you're offering, then all of a sudden it's like, well, we need to have something that's just audio based. That's, because of the recent changes. So I think that's why it's even more important that you can help those folks with discounts across, especially if the vendors are offering different types of services, like some like high end, like good, better, best. And you can provide them with some guidance with that, especially going through something like this.
Yeah, sure. And then there's opportunities for us to assist with an RFP process and things like that as well. So say they want to look at where can we get the best opportunity with translation service or office supplies. We can line up our vendors and say, hey, we're doing an RFP for our members, for our 52 members in Massachusetts, health centers. You gotta vie for this opportunity. This is the way we're going to do it, and this is the way we're going to approach it. We can do more of that as well. And I think that, that can be something that's a benefit that we can provide. See, our members don't pay us anything. Our members don't pay us a dime. So there's no risk for our members to be a member of CPG.
Right.
You know, the more members we get, the more work we have to do. But at the end of the day, it's going to help them. It's going to help us. You know,
it's going to help them too, because the more folks that you have on board, the more leveraging you're going to have for negotiations, right?
Correct. So when, you know, we just had an example of that, you know, with an opportunity that we had with one of our pharma contracts. We have two main pharma contracts, and one of them, you know, just because of that spend and because of the opportunity, as we grow, they grow, you know, and so it's a win-win, or as Phil would say, our vice president for strategic sales and marketing, it's a win-win-win. You know, CPG is the third win there, but you know what? The members, the vendors, and us, when we can make that happen, it's a good day. You know, and so, you know, that's what we're really all about. And our vendors pay us an admin fee, and really that's how we keep the lights on.
Okay.
You know,
ready for a really terrible question? So you guys have the Mass League as like an authority over you, or I'm not sure if it's an authority.
We're a wholly owned subsidiary of the Mass League.
Mass League. Okay.
Right.
So I want to talk for a second about conflict of interest. And, you know, again, here's what I want to know, because I'm not asking you to speak anything out of turn about where you work, but we talked before about vetting vendors. How do you make sure, like, because I always get worried about things like, okay, and I'm not even sure who the president, actually, no, I invited whoever that is, the president of the Mass League. What's his name?
Michael Curry.
Michael Curry, yeah, I invited him, so hopefully he's watching too. Although he's probably going to get mad at me for this. But let's say Michael his best friend owns like a credentialing company, and he wants to create an exclusive contract with them. How is there a board of checks and balances or something like that that prevents? And I imagine Michael's a fine individual who would shoot down anybody trying to do a sweetheart deal like that. But can you explain to me how your board operates, or how that communication works, so that you are always looking out for the interests of the health center?
Sure, I understand the question. So we all sign a conflict of interest statement, first of all.
Oh, okay.
We all do. My team does. Everybody downstairs at the Mass League does. Michael does. I'm sure our board does. CPG doesn't have a governing board. Our direct governing board is the Mass League board.
Correct. Yeah.
Right. And you know, we're very cognizant of relationships too. So relationships, even when I was at Greater Lawrence, I mean, you know, John and Bob, you know, they had relationships in the business community as well. You know, and I was never required to use anything or anybody. And you know, we take referrals from everybody, but we're not in that. So we do have checks and balances for all.
Right. Yeah. I mean, I can attest, even as a board member, I had to fill one of those out.
And we have a legal team here.
Right.
We have an internal legal team
that audits and makes sure
that we work very closely with.
Damn good answer.
With the Mass League. The Mass League has a legal team that we get some significant support from.
Okay.
You know, prior to my coming here, about a year before that, that's when the legal team was really starting to develop. There's a group of attorneys. We have a chief legal counsel, general counsel, as well as an associate general counsel downstairs. But it was always outsourced, at least for CPG.
Okay.
It was outsourced. So getting contracts done, getting agreements done, things like that, all had to be outsourced. And you can imagine the time that took
a lot,
to do that.
That's not easy.
It still takes a significant amount of time because there's a burden on our legal team, because there's so many different contracts and grants and things like that that they have to review. But every single legal document that I sign is reviewed by them before. That's
great. That's really great to hear.
Before anything gets signed.
Yeah.
You know, and up here right now, I'm the only one. There's only 3 or 4 signatories in the whole company, in CPG and the Mass League combined.
Okay.
So we're very cognizant of those types of issues, how they could arise.
Yeah.
Yeah.
Okay.
Yeah.
That's a fantastic answer. And it's great to hear, because I think that a lot of people worry about that. I mean, I've heard vendors say different things about like, Mass League, this, that, and the other. But I think that, a lot of people complain, especially if they don't get a bid or something like that. People have different reasons.
Sure.
And now I just realized I just called out a couple of my friends that are probably going to yell at me for that. But that's great to hear that there's a whole system that forces integrity. Not to say that any of you don't have it, but and you have a legal team that even backs that up. That's fantastic. That's great. Okay, I am going to see if we have any questions here. So I'm going to ask if anybody has a question. I'm going to look over here. Let's see what we have so far. Oh, Rosemary Svada, the person we had on last week. Did you connect with her, by the way, recently?
On LinkedIn that day while you were talking to her, I sent her.
You sent her a thing because I was looking at that. I think I went in because I wanted to invite folks to let them know that I was inviting you. So then I came up with the idea this time. I wish I had done it last week, to look at every mutual contact we have.
Yeah, it's good.
There were 9 pages, which I think there's probably 10 on the page.
That you and I have?
That you and I have mutual.
Yeah, I'm not surprised.
Which is a lot of clicking back and forth for the invite. So, but when I saw Rosemary there, I was like, that has to be from this Tim Talk thing. So
yeah, I drive my team crazy. I'm laughing. I'm looking over it. Because I'm a LinkedIn. I don't want to say. I'll say a LinkedIn junkie. You know what I mean? So I think it's a great tool when it's used the right way.
Yeah.
In terms of making that, primary contacts and networking, we have a presence on LinkedIn that we've grown over the last 2 or 3 years, which has been great. So, that's why I did it though.
Yeah, I think LinkedIn's. I think a lot of people just do self-promotion on LinkedIn, which is fine. I think that's what the majority of folks do. Like, oh, I just got a new job here, or I got a promotion, and I think that's great, especially to connect with people who kind of like Facebook. Where, half of my friends are just high school people who I never either hung out with them or certainly don't now.
Sure.
But it's sometimes, I don't know why, you get something out of seeing like, oh, they got a family and they're doing this, that, or whatever. And I think with LinkedIn is cool too, where people, when you've crossed paths with them, like, how we're doing right now. And I always like catching up with folks about with things. But I think also I find that company page is interesting too. Like, so Mass Medical Society was did this great thing. Like, they do a lot of good advocacy things. There's some things I don't like about them with, I should probably have them on this. That would probably be good if I had a rep over there, but this might knock me out of the contention for that. But I think that there needs to be a change at some point in philosophy as it pertains to like nurse practitioners over there. They do great advocacy. They're doing this great thing right now, big push to limit prior auth flexing from insurance companies and really holding the task, which is everybody wants, because it's so not about patient health and it's so much about not paying patient bills and confusing folks on the practice side. So I love a lot of what they do, but oh boy, I would love an opportunity to, I should reach out to some of my folks over there to see if we can get them on the show. But I think the company stuff is really interesting too. And it's great to learn more about CPG, and I'm glad that you landed here. I think this is a perfect spot for you because you can speak so much from the heart about this stuff. And are you guys involved in lobbying? Like, I technically would say at the health center, that's when you go to DC for the health center, when you worked over there, that's really lobbying, right? You're going there to try to.
Yeah, technically.
Your pockets weren't probably lined.
Federally funded health centers, entities like we were at Greater Lawrence, we got to be careful about calling it the lobbying. So
it's probably a bad word for it, but
yeah, we do advocacy work. We try our hardest to work directly with the staffs of different legislators, whether it be local, state, or federal.
Well, they depend on you though for that.
Yeah, they depend on that for the information about it,
right.
And about our constituency or our getting testimonials and things like that. What I've noticed, and the reason I got into it at Greater Lawrence, John Silva, definitely, Michael Curry, Jim Hunt, Karen O'Toole, who's not here with us anymore.
Yeah,
those folks introduced me to it.
Yeah,
and that's why I loved it so much.
Yeah, all very big names in the field.
Yeah, but we don't do a lot of that here at CPG. I was in DC last week.
Yeah.
I was in DC last week because early on when I got here, a year before I came here, there was a group, I call it like a think tank, a best practices GPO affiliated
Like
group.
a mastermind type of group?
Yeah, it's called the Healthcare Group Purchasing Industry Initiative,
Okay.
HGPII. And
'Cause
so
we
they
needed
call it
another
so they call it
acronym.
HIGPI, you know, and
Okay.
Phil and I went down last year, and this year they have a best practices forum. It's a one-day forum down in DC at a local law firm. That's the few of the partners are former national U.S. legislators,
Okay.
congressmen, and senators. And so we go down there, and some of the biggest healthcare related GPOs in the country are represented there.
Okay.
So, we go down there, we listen to the different discussions and the different panels. There was one last week on AI and the influence of AI in healthcare and what it means for GPOs, all that type of stuff. Supplier diversity, which I should probably mention to you too, is something that's an area of focus for us as well.
Yeah.
All those things are talked about, and that's why we participated in that in DC last week. So that's kind of the level. We depend on our membership organizations to do that advocacy,
Right.
even for the GPOs as
Right.
well, So one area of focus that I didn't mention earlier that I would be remiss is if I didn't, is our work in creating a healthy environment and a intentional environment for diverse suppliers.
What do you mean by
So
that?
what I mean by that is supplier diversity is a big thing in this country through GPOs that should be more focused on. It's giving small businesses, minority-owned businesses, veteran-owned businesses, women-owned businesses an opportunity to participate in the GPO process, in the bidding process, and the business development process. And what we're trying to do is attract more diverse suppliers throughout the country to be part of our network.
Okay.
So
Yeah.
it's something it's taken a while to pull together,
Yeah.
but we have some people that are helping us. We're tracking spend because a lot of our national big time suppliers, the big ones, they actually have a network of diverse suppliers within their own network that they depend on as well. So that they call that tier 2 spending. So we're even starting to track that as well. So
Interesting.
it's really something that's important. And it's important, by the way, to our members, because when they're going through a grant process, there sometimes will be a question in some of those grants. It says, what percentage of your vendors are diverse suppliers, things like that.
I wasn't going to go that far,
now,
but that's interesting.
whether or not that will continue based on what the standards are from the current administration, I don't know. If that's going to change.
Right.
My hope is that it doesn't change, but we're full steam ahead. We're still working on it. We're still trying to pull it together, provide opportunities for diverse suppliers to be part of our network, so then we can promote them to our members.
Okay. Yeah. And do you see, so that's really interesting that grants are tied into that, which I'm not surprised about. But what I was going to ask before you got there was, are you doing this because of a part of your mission, because of the space you're in, or because some of your clients have been letting you know this is becoming a priority? And this is a cynical part of me, but is it, no, because I mean, the thing too is like, I was going to get into is like, our health centers doing this because they want to get the grants, and I'm sure that's always. I mean, there's a focus of all health centers to make sure you procure as many grants as you can, because that's a huge part of the income for any health center.
Sure.
I'm so focused in rev cycle about like insurance procurement or getting cash from like self-pays or work comp or whatever, but without grants, every health center fails. So that's extremely important. But also health centers are so focused on helping out marginalized groups. So they naturally are probably also wanting something like this. And you folks being associated with them are also wanting something.
Yeah,
like
you just actually stole my answer.
Sorry.
No, that's okay. I was going to say, ultimately, our belief is, and my belief has always been, first of all, very simplistically, it's the right thing to do.
Yeah.
The second part of that for 1A would be, think about the constituency that health centers are serving, how diverse it is.
Right.
And doesn't it make sense that our vendors, to me, it makes sense that we have an opportunity for our vendors that match that have the opportunity,
right.
to serve and to be part of the process.
Yeah.
You know what I mean? At the end
I
of the
wouldn't
day,
buy that if it was honestly in any other segment, because I feel like so many in business, so much stuff, you have so much fake posturing, like how everybody cares about the gay community during Pride Month. But then all of a sudden they don't, and before that they don't, or something, like, there's always this big push and for whatever the situation is at the moment. But it's a 24/7 thing in the healthcare center environment. This isn't like a show. This isn't like we're just trying to pretend here that we care about this, that, or the other. It's never ending. This is what everybody deals with in this industry, 24/7. So I totally get that. I think that there's a lot of other markets that I wouldn't see that being anything other than just trying to get cash from grants. But it is important to really push that, because that, again, it's going to help folks in those markets too. Especially for local and small business.
And some of our larger national vendors, they embrace it too.
Yeah.
They don't see it as a challenge to them or as a threat.
Mm-hmm.
They see it as opportunity as well. And they see it as we're doing the right thing also.
Yeah, I mean, it's consistent. It keeps with the integrity of all your organizations that are in this market, which is great. Yeah, because I remember when I first came, one of the first things I learned about was that Canada program for the supervised injections. For folks.
Yes.
And so that was mind blowing for me.
Yes, I spoke at a conference for the Canada Association of Community Health Centers, so they call it CAC as opposed to NAC. I went up there. Probably it was John's second to last year, and I went up there. They asked me to come up and speak about grassroots advocacy and what we were doing. I was involved with NAC at the national level with that, and one of the sessions was on that program, and it was unbelievable. It was eye opening. It was just amazing what they were doing with the heroin population, and what they were doing to safe injection sites and things like that.
Yeah, and I think it's a lot. There's a lot of things. I feel like with any industry, when you look under the hood, there's so much more there, and it's hard to understand, and it's a lot easier to cast actually, Rosemary said on the first episode, she mentioned that before she got into addiction medicine, how she thought that like methadone clinics and things like that, you're just trading one drug for another.
Right.
And when you first hear about folks that are supervising others injecting heroin, it just does not sound like medicine. But when you get in and you understand that these folks have gone through what they've gone through, and they have no one that they trust, they're not going to trust you. You try to set them up with counseling, they're not going to trust to open up to a counselor. Right. That's going to be months down the road. And this Canadian program was unbelievable, and it inspired. I mean, we copycatted them and have had, just to get 1 degree better, and it might be a very long road, and you might have setbacks and stuff like that. But I think we all so many people have family members that they've lost to this, that it's like a demon took over their soul, and it's, I don't know who this person is anymore. And it's terrible. And there are some folks, like I have a friend I haven't connected with in a little while, and I remember she was an employee of mine, and she was one of the rare ones. She went off to California, and then her first stint of getting help came out clean. And typically it's like 5 to 7 if you even live that long. It's such a tough environment. But this is the stuff that is getting accomplished, like the stuff that nobody wants to touch, the stuff that does not have the greatest prognosis usually. But it's tough work. So do you feel like, so you said you want to stay in this market for the rest of your career. Can you tell me about, I imagine you're not thinking of a next step. I'm sure you're very happy here. But is there anything in the FQHC market, if somebody, let's say, is watching here and wants to get into this market and help out these folks, where would you suggest that they get started? Like, what's the most needed right now, do you think, for folks that are that want to help out community health centers? You
mean in terms of a career, or do you mean in terms of volunteering, or do you mean
any of the above? Like, so what is,
I think health centers need strong boards. I think they certainly need that. I don't know how many of our health centers are really delving into like day-to-day volunteer work. I think there's some criteria that has to be addressed and dealt with in order to get someone in the door to be a volunteer at a health center. I know we didn't do much of it when I was at Greater Lawrence.
Yeah.
I think for a career path other than the clinical areas, because they're
Mm-hmm.
all, I think there's workforce challenges for health centers and open positions and things like that,
Right.
frontline people, registration, medical assistants,
Right.
I
Because
think
salary
those,
is usually lower. Even like the clinicians that go there are inspiring because they could go work at another hospital or something like that,
correct.
and they could get significantly higher.
Correct. I mean, that
salary.
was one of the things that I loved about Greater Lawrence too, being the first in the country to have a health center owned and operated residency program.
Right.
Gold
Right.
standard. It still is. So, and it's still got people there that have been there since they were residents themselves.
Yeah.
Which is
Yeah.
it tells a great story.
I mean, when I left, they had, I think, 10 people per class. Maybe they moved it up to 12, I think, when I left.
They might have, yeah. It might, yeah, you're right. You're right. It might be up to 12. I'm not
12 per
100% sure,
class,
but yeah.
I think.
Yeah.
And they would get like over 1,000, like all around the country, the amount of folks that were applying to be a part of that. So they were getting some amazingly fine, talented folks who are ready to start their careers. And I think I want to say there was a requirement, I'm not sure, for all residents to learn Spanish when they were there as well.
Well, they go through a Spanish immersion program.
Okay.
Yeah. And, that's the other thing unique about, Greater Lawrence. You would think, and we were looking at translation spend, interpreter spend, like medical interpretation spend, from a GPO perspective with our vendors a couple weeks ago. And Greater Lawrence was probably one of the lower ones. But the interesting thing is so many of their staff are bilingual.
Yeah.
It's amazing.
I don't know if I ever met anyone that wasn't. It was yeah.
Yeah, and it's amazing. So the residents do go through an immersion program up at, I think it's at Dartmouth,
Okay.
the summer that they get there. And then they slowly work through it as they're, and Greater Lawrence, I think, is still probably one of a handful of 4-year programs throughout the country.
Okay.
Most of the programs are 3 years, but Greater Lawrence built in a 4th year for specialization.
So there's been a lot of copycats through the country now. There's several other programs.
Yeah, there's several other residency programs. When I
That's
left
great.
Greater Lawrence, I think it was up to close to 60, but
60 other programs
throughout the country
that are health center driven.
Yeah,
that's awesome.
Yeah. And I think that's growing.
Yeah.
Hopefully. I mean, they're going through some challenges too to get reappropriated with funding. They're up against it again now.
Okay.
I just saw the gentleman that we used to work with from a law firm down there, who's our legal counsel, in that, and connected to the Hill, and
right.
He was telling me they're going for another reappropriation soon.
Yeah.
So,
I think one of the good things too, if there's anything good about the big beautiful bill too, that for health centers, I know that other than the childcare thing, I think they secured funding for 2 years, which I feel like it's typically a year to year, right? No, it's usually a multi-year deal. Okay.
Yeah, usually.
I'm trying to remember. It just seemed like there was always
but it's always
this potential freeze coming up.
We just finished, and now you're 6 months later. You're going back to get ready for
John
the
used
next
to
time
freak
around.
out like crazy.
Yeah,
crazy. I mean, I don't blame him, but
yeah.
I mean the sick part of me enjoyed it because it was like you want people that passionate, and he would just be ranting and raving and
I remember the time when you were probably 2nd or 3rd year board member and you came down to DC with us. Do you remember that?
Yeah, of course I do.
Yeah.
That was an absolutely. I had never been to DC. Actually, that's the only time I've ever been to DC.
Oh, really?
And it was an amazing experience. Yeah, we met Senator Markey out there.
Yeah.
And some other folks. What's her name? Lori Trahan.
Lori Trahan. Yeah.
Who I absolutely loved her. Which you said before, she still is.
She's still involved. Yeah,
still in office.
She's still in office. She had, when you came down with us, I think she had just taken over after Nikki Songas.
She did.
She just won that seat after Nikki had retired.
And what is she, like 8 feet tall, right?
No.
But yeah,
Division I athlete, former Division I.
I'm quite aware. Very clearly.
Volleyball.
Yeah.
Yes.
Oh yeah, she was a volleyball. That's what it was.
Yes.
Yeah.
Yes.
No, she was. I can't recall my conversation with her, but I just remember it was. She just gave what anybody really cares about. I think with politicians, because it's so hard dealing with politicians. Just came off as like a human, And because they so often don't, they often come off as
she's
like
very,
robots.
very down to earth, and she cares about it tremendously.
That's great. Okay. All right. Let me see. Okay. I don't think we have any other comments here. So last chance for anyone to give comments. We're just hitting the 12 o'clock hour here. So I want to thank whoever it was that attended here. And any parting words, Rich?
No, thanks for the opportunity. I think this is great. I think it's great that you're doing this. You know, you got a whole host of different speakers in this stuff for Tim Talk Live. I think it's great. And the fact that we're involved, or I had the opportunity to be involved and talk about CPG and health centers, is, I really appreciate it.
Absolutely. So, yeah. And if you have any other folks too, although Michael might not like me either after this one, but if you have other folks that are interested in, or that you think, like, because what I'm looking for typically are people who are doing things that other folks don't really know about, people who are innovative, people like you've had a very interesting career, and a lot of it dedicated to folks that desperately need people like you that are going to be impassioned about what they do. And I mean, just for the folks at home, if you do get into the FQHC side of things, I mean, community healthcare is filled with passionate people who really actually care and are trying to do the good things. And that's what you'll see on these things, are all going to be passionate people. But it's a pleasure to have you. And as a long-term friend, my friend, thank you very much. How did we do? Does he still have his job? He's good. Okay.
If I do, he does.
All right, guys. Thank you very much. We'll see you at the next one. Oh, wait, hold on. I did that wrong. I'm still getting used to this stuff. Hold on. We're still on the air and we're ending. Oh, and we got Jonas Bromberg. Hold on. I should probably do a little plug. So Jonas, he integrated behavioral health for like 100 practices that are affiliated with Children's Hospital in Boston. He probably wouldn't be calling himself all this, but I think he really is the architect. He had a lot of folks that he worked with, but he did an amazing job. We'll have him on next week and talk about how it's going. I have some critiques about the program. As you know, I'm not really a fun person to deal with, but we'll get his opinion on where things are now and what he's up to now, because he's no longer over there. So we'll see you at the next one, guys. Thank you very much.